Thank you very much for your kind introduction, and many thanks for the invitation. It's truly an honor to be here on behalf of the EBMT. So my talk today will be to discuss of a difficult and challenging topic, which is represented by timing for transplantation in myelofibrosis. And this is the agenda I will try to follow today. I will go through the prognostication and treatment goals for myelofibrosis. Then we move to current treatment option, their limitation, and possibly the integration into patient journey for transplant. And then we will discuss about pros and cons of early versus delayed transplantation. And finally, I will try to discuss an up-to-date approach with risk-adapted models for a comprehensive care. So moving to the first part of my talk. When thinking about the treatment goals for myelofibrosis, for sure, our primary aim is to reduce splenomegaly and improve constitutional symptoms that can affect severely the quality of life of our patient. Then we have also new drugs affecting cytopenias and improving our ability to treat those cytopenic patients. But ultimately, our primary goal is to prolong overall survival. But we have also to keep in mind that these treatment goals are possibly changing over time based on the patient and the disease characteristic. And so we should be ready to adapt our management accordingly. And here, when it comes to prognostication, we have now several prognostic models, and in dark blue are those most widely employed in clinical practice and that can be applied both at diagnosis and during the course of the disease. And based on clinical and molecular parameters, they are quite effective in dissecting myelofibrosis population, identifying those patients at low risk with a very prolonged expected survival. And on the other side, the patient at intermediate 1, and particularly those at intermediate 2 or high risk, face a very poor prognosis with a life expectancy of less than 5 years, making them the right candidates for a curative approach such as transplantation. And indeed, the transplantation, as all of you are aware, is the only curative option of such a disease. And even if the proportion of transplant for myelofibrosis represent only only a minority of the entire cohort of transplant indication in Europe, the numbers of procedures for myelofibrosis is increasing year after year. And this is partially due to our improvement in transplant platform, and we are now allowed to deliver such a curative option even to older patients with more comorbidity burden. And looking at the treatment option and their limitation, we know that we have now several JAK inhibitors available in clinical practice. At least in Europe, we have 3 compounds. Ruxolitinib, the first one that was approved many years ago, followed by fedratinib and momelotinib. And then we have pacritinib that now is available in a phase 3 trial investigating its role in cytopenic patients, but many other compounds and combinations are under evaluation and possibly will enter the clinical arena in the next year. So when thinking about the efficacy of such compound, a remarkable spleen reduction and symptom response is seen during treatment in the vast majority of patients. And among these compounds, momelotinib has a unique mechanism of action because given its ability to target the activin A receptor 1 gene, is able to partially restore the ineffective erythropoiesis, leading to improvement in anemia, response with limited hematotoxicity as compared to other compounds. And so when thinking about the right positioning for each JAK inhibitor, we should treat patients with, without thrombocytopenia with ruxolitinib and fedratinib, and we may reserve the use of momelotinib to those cytopenic, in particular thrombocytopenic patients or with anemia, in order to optimize the clinical journey of the patient. And for sure, there has been a lot of improvement in patient survival thanks to the availability of such compound. And this is the real-world experience of the US, where more than 1,000 patients were analyzed. And as you can see here, after the approval of JAK inhibitor, the overall survival of myelofibrosis patients increased. But this was not only related to JAK inhibition, and we have to keep in mind that several other aspects may have played a role in this improvement, as documented by the general improvement of survival even in patients without JAK inhibition. And this is for sure given by the disease awareness, but better supportive care and better ability to deliver transplantation in older and frail patients. And indeed, the vast majority of patients receiving JAK inhibitor will discontinue the treatment. It is expected that around 50% of patients will lose their response or will develop some grade of toxicity, and at the end, eventually, will discontinue the treatment. And the prognosis of such patients is extremely poor, of around 1 year. And the same results came from an Italian consortium study on 500 real-life patients receiving ruxolitinib, where ruxolitinib was discontinued in around 30% of cases, and the probability of discontinuing this treatment was higher among patients with advanced stage of disease, typically the patients who are candidates for an early transplantation. So when thinking about the treatment option for myelofibrosis, one of the most challenging aspects is to refer a patient who is doing super well while on JAK inhibition. So, and with the aim to address this unmet need, the RR6 model was developed. And as you can see here, despite its inherent limitation, this model was able to find around 90% of patients who are actually candidates for a long-term benefit from JAK inhibition. However, as you can see by the variable included in this study, it's unlikely that those are the patients who are candidates for transplant because they usually present a low-risk disease. And on the other side, the spleen size represents one of the major factors affecting transplant outcome, with a patient submitted to transplant with a spleen size less than 5 centimeters below left costal margin, projected to a better overall survival as compared to patients with larger spleen sizes. And this was particularly true among the patients receiving ruxolitinib, where in this EBMT experience, it was clearly demonstrated that the patient submitted to transplant while still responding on ruxolitinib had a better event-free survival as compared to patients without any treatment or to those patients who had their response lost during the course of the therapy. And all these data lead to the development of this position paper, where it was clearly stated that all patients with possible candidates for a transplantation should receive a treatment with a JAK inhibitor tailored according to the patient features at the maximum tolerated dose in order to achieve the better spleen control before transplantation. And in case of non-responsiveness or progressive splenomegaly, secondary options should be pursued. Among these, switching JAK inhibitor can play a role. Of course, we can obtain some meaningful responses with switching JAK inhibitors. However, usually responses are not very long-lasting. And in progressive case, we can also consider splenic irradiation or splenectomy. depending on center availability and experience in the field. However, I would like to highlight that in these cases, transplant should not be delayed because usually the responses obtained are very short time. So let's move to the core of the today presentation, so the issue of transplant timing. Some years ago, the SSBMT published this interesting study, including 2 independent databases of patients, one of 551 transplanted patients within the EBMT, and a cohort of more than 1,000 patients who did not receive transplant in the era of JAK inhibition. As you can see here, patients at low risk, according to DIPS, a delayed in transplantation should be pursued because they present a better overall survival with medical treatment as compared to transplantation. But on the other side, patients at intermediate 1, and particularly those at intermediate 2 or high risk according to the dynamic IPSS, presented an advantage with transplantation as compared to medical treatment, even if we can observe a worse outcome with transplant within the first year. And this is very important to keep in mind when counseling a patient with MF for a transplant. And indeed, the delay of a transplant can carry some risk, for instance, the disease progression. The Hamburg group published quite recently a paper about the role of transplantation in accelerated phase disease, as defined as the number of circulating blasts between 10 to 20, and they were able to demonstrate that transplant can cure also accelerated phase of disease. The patient submitted to transplant in this condition had similar overall survival as compared to chronic phase disease, but they face higher risk of relapse. On the other side, patients who develop secondary ML has a much worse prognosis with around 30% of long-term curative probability, particularly in the case of complete remission before transplantation. But we are not aware of how many patients can have their transplant canceled due to the worsening of a clinical condition. So in this case, we should prevent the occurrence of disease progression and to go to transplant before this unlucky situation. With the aim to catch the right timing for a transplant, a multi-state model was developed with this complex multi-state Markov statistical method. And the aim of the author was to define and to predict the disease trajectory and to intercept the right point for transplantation as stratified by DIPS score. As you can see here, all the patients with PMF benefit from a transplant. However, sorry for that. However, the intermediate to high-risk patients have a very strict, very narrow window where they gain the maximum benefit from a transplant, from a diagnosis, just less than 2 years, while intermediate 1 and low-risk patients have a larger time frame for clinicians to decide for an upfront or a delayed transplant. And these findings support the current indication for early transplant in high-risk patients. Currently, there is a new paper in production led by Nicola Polverelli and an international consortium evaluating the same method within a molecularly annotated cohort of MF patients. And we will see in the next month, hopefully, if the same result can be produced. In order to aid the decision of a transplant, the myelofibrosis transplant scoring system was developed. And this score includes both patient-specific, disease-related, and transplant-related features, and it was found to be very accurate in defining post-transplant survival due to its precise evaluation of non-relapse mortality. However, I think that many limitations are present in this study. The lack of a significant number of mismatch-related donors and almost the absence of PTSI GVHD prophylaxis limit the actual validity of such score, and also there was no information regarding comorbidities. And as you know, now we are doing many transplants from haplo-donor in more comorbid patients, so this will need to be refined in the future for sure. And indeed, the comorbidity plays a significant role in predicting transplant outcome, as you can see in this another EBMT study. And on the other side, the weight loss, more than 10% within 6 months prior to transplant, was associated with an increased non-relapse mortality, suggesting that symptomatic patients should be referred early for transplant rather than wait for weight loss to occur. And finally, these are the recently published EBMT ELN recommendation, where it's clearly stated that all patients with intermediate to high risk according to DIPS score or MIP70 high risk and molecular transplant scoring system low intermediate should be referred early for transplantation. In the setting of intermediate risk category, transplant should be pursued only in low risk patients. But these statements are usually based on expert opinion rather than clinical trials, because there are no clinical trials, randomized prospective study evaluating this specific scenario. So we will see if these are real recommendations or can be expanded. And in fact, an up-to-date analysis carried by a multi-center group of European countries tried to deal with this aspect, and it was collected a transplanted cohort of 231 patients and compared to two different cohorts of non-transplanted patients coming from two different institutions in France. And a propensity matching score was applied in order to balance for confounding factors. And once again, this experience documented that in the early period, within 1 year from transplant, there is a benefit in a transplant approach, but later on, after 1 year landmark, transplant have a benefit in all patients, particularly in those at high risk molecular PSS 70, regardless the MTS score. And also in the MTS, and also in the MIP70 intermediate category, there is an advantage in the MTS low intermediate category. So these results seem to expand the real applicability of transplant to a larger number of patients. So let's move to the last part of my talk, and I will try to give you a looking forward vision of the early future. So as you can see, the availability of novel drugs force us to improve our ability to understand the right timing for transplant. And as you can see, the available prognostic model based on just a few number of variables are not sufficient to give us a right definition of the prognosis of such patient. And the first approach to this direction came once again by the EBMT, and particularly by Juan Carlos Hernandez Boluda and Adrian Mosquero Orgueira, who developed a machine learning model based on 52 prognostic variables taken by a cohort of more than 5,000 MF transplanted patients in the recent era, including also haplotransplant with all GVHD prophylaxis. And they were able to build a prognostic model who demonstrated a remarkable ability, in particular, to identify a larger proportion of high-risk patients as compared to the classical Cox-derived score, and almost doubling the ability of the traditional prognostic model. So here comes with a practical example of a case that can occur everywhere at our clinic. So this is a 65-year-old male subject with primary myelofibrosis, moderate anemia, leukocytosis, and thrombocytopenia. He has 3% of circulating blast, and the molecular analysis documented the presence of an high-risk mutation, ASXL1, and the patient had no significant comorbidity. So this is the case typical of early transplant. And therefore, we need to search for a donor, and the patient has two different donors. He has one 30-year-old sister, haploidentical. In this scenario, the patient will receive a reduced intensity conditioning regimen with PTSI. And in the international registry, he was able to find a 9 out of 10 HLA-matched donor younger than the sister. And in this scenario, the transplant protocol will be the flubu ITG plus cyclosporine and methotrexate. What is the best choice? Now, if we run the artificial intelligence model, we can detect that the prognosis of such patient with using a mismatch-related donor is around 28% of no-relapse mortality at 2 years. But if we consider the 9 out of 10 unrelated donor, the patient fell into the high-risk category with an increase in no-relapse mortality of 31%, making the decision to proceed to transplant with mismatch-related donor more straightforward. And so I will leave you with some take-home messages, even if a lot of questions still remain. For sure, the early identification of transplant candidates is critical, and this should occur within a multidisciplinary team of experts in the field of myelofibrosis. And in this regard, the integration of both clinical and genomic data is of a paramount importance to dynamically evaluate the patient at diagnosis and during the course of the disease. Based on the current indication, the patient at high risk, according to dynamic IPSS, molecular IPSS, or MySick prognostic model with low intermediate MTSS should be referred early for a transplant, but maybe in the future there will be an expansion to this indication. And we should aim to transplant the patient at the time of the best response to JAK inhibitor whenever possible. In this regard, donor search should be started early in order to avoid possible delays when transplant became indicated. And finally, the future is bright, and machine learning tools may support the decision for a transplant in such patient. Here is the link you can connect to in order to precisely evaluate your single cases. So with that, I would like to thank you all, and particularly my colleagues and the nurses of the unit of bone marrow transplantation and cellular therapy at the Fondazione Policlinico San Matteo in Pavia, Italy, but particularly EBMT and the Chronic Malignancy Working Party, and you all for the attention, and I am more than happy to receive any question from you. Thank you.